Good evening, everyone. A very warm welcome to all our esteemed faculty, panelists, and delegates joining us today for this very special webinar on ethical dilemmas and decision making in high risk pregnancy. On behalf of Artist for Her and our very valued academic partner, Farmed, it gives me great pleasure to greet this gathering of distinguished clinicians, academicians, and thought leaders in women's health. As we all know, modern obstetric practice often brings us to crossroads where science, ethics, and human values intersect. Navigating these gray zones requires not only knowledge and skill, but also empathy and ethical clarity. Today's session, led by our scientific convener, Dr. Hema Divakar, and our keynote speaker, Dr. Sanjay Gupte, a visionary in this domain, promises to enrich our understanding of how decisions in high risk pregnancy can be made responsibly, compassionately, and ethically. We also extend our heartfelt thanks to our expert panel and moderator, Dr. Chinmayi Ratha, Dr. Sita Ramamurthy Pal, Dr. Bijoy Balakrishna, Dr. Ashok Khurana, and Dr. Bhela Bhatt for joining hands to share their perspectives and experience. Together, through dialogues like this, we continue to strengthen our collective mission to promote safe, ethical, and evidence-based care for every woman everywhere. Thank you all for being with us this evening. We wish you an engaging and thought-provoking session ahead. Dr. Hema Divakar, we are privileged to have this academic initiative convened by Dr. Hema Divakar. She's the CEO and chairperson of Artist for Her Bengaluru and division director, FIGO Well Women Healthcare. Dr. Hema has been a national leader and global advocate for women's health, blending innovation, ethics, and empathy in every initiative. She continues to inspire excellence in maternal and reproductive healthcare across India and beyond.
Thank you very much, Purni, for that wonderful start for this insightful deliberation this fine Saturday evening. And we welcome all the delegates on behalf of Artists for Her and Farmed. All of those distinguished faculty that you see on the screen here are very beloved friends, and at a drop of a hat, they will say, yes, we are in it. And that is what inspires us to do more and more so. A heartfelt personal thanks to all my distinguished friends and colleagues. The webinar today begins with the keynote by none other than our very beloved Dr. Sanjay Gupte, specially suited for the topic of ethics in obstetric practice, because he led the FIGO Committee on Ethics, and his work was immensely appreciated by the global leaders right across and is being referred to again and again and again for many topics that he has placed a collective vision on what ethics should mean to the frontline healthcare providers. We are deeply honored, Dr. Gupte, to have you with us. He is the director of the Gupte Hospital, Pune, and needless to say, an eminent OBGYN with multiple degrees from A to Z. He served the profession in multiple national and international capacities and always willing to give himself away to do good to a larger community. He is widely respected for his contributions in medical ethics, medical legal awareness, and safe obstetric practice. He will deliver today the keynote address on ethical dilemmas and decision making in high risk pregnancy, setting the tone for this very important discussion. As we have always believed and said that he is a visionary in this domain, understanding how decisions in high risk pregnancies can and should be made responsibly, compassionately, and ethically. I repeat what Dr. Purni said again, because in this era of eroding trust between the doctors and patients, this fulcrum of ethics becomes all the more crucial. So over to Dr. Gupte for his keynote deliberation.
Thank you, Dr. Hema, for this great opportunity, because I think ethics is one field where we are, as far as our country is concerned, we are a little lagging behind. we don't give it as much importance as it should be, actually, given. And that's why it's important that, we talk about ethics more and more in our country, and, we appraise our, colleagues, including our the whole faculty, regarding what it means by actually ethics itself. So let's start directly with what FIGO does and what FIGO has done about the ethical practice in our faculty, right? See, we as obstetricians and gynecologists, we deal with beginnings of human life, and we are often involved in complex decision making. See, when it comes to especially the MTP, you will realize that the somebody we call otherwise is our patient. We are allowed to terminate also. The fetus that we are talking about. So in this context, the importance of consistent and relevant ethical practice becomes obvious. But do we really know what dictates these rule of ethical practice? So let's start with what is ethics. Ethics is the science of morals, the branch of philosophy that is concerned with human character and conduct. And this philosophy is there for ages, right from the beginning of the social human kind. Now, so any action within the doctor-patient relationship will have an ethical dimension, because we deal with human beings and patients, and it's not only human beings, but when it comes to animals also, the ethics matters, as we know, right? But the ethics as branch of moral philosophy has ancient roots in many cultural traditions, especially ours. But remember, bioethics dates back only to 1960s. And bioethics concerns correct conduct relating to human medical biology. And why this bioethics came in? Because as the medical technology started advancing, especially when it came to life prolonging conditions like putting patients on ventilators, and so how long do we keep prolonging the life? When do we shut off the life? Then came the infertility now, and now assisted reproduction, where actually we are bypassing the fertility. And more relevant to us are technologies concerning fetal-maternal interventions also. Now the next that is coming in is modifying the genes and gene editing. That again will have its own ethical, bioethical aspects. So 4 principles have been laid down as far as the principles of ethics are concerned. One is beneficence. It should be doing good to the patients out there. Then no malfeasance. We shouldn't be doing any harm. Then the respect for autonomy of the patient, the decision making by the patient, and justice, that is equity, that should be there for everyone across. So, but what happens is, in multicultural and multi-dimensional society like ours, something may be right in one particular respect, but the same thing may be wrong in other situation. And that's why there are challenging dilemmas how to act when these principles are actually conflicting with each other. For example, if autonomy is allowed to override other considerations, medical imperative to do good for like beneficence is hampered. Example is refusal of cesarean section by the patient, which we'll be talking about little more later on. Then in circumstances of legality may come in the way of confidentiality or autonomy that we know about, POXO Act in our country. And whenever legal issues are concerned, then they have to be given priority. So how do we actually balance these competing ethical consideration becomes an issue, and it depends on the situation. For instance, physician, if you are dealing with a childbearing age person, then our decisions will be different. Suppose we have to deal with an ovarian tumor, we'll try and save the ovary as much as possible. But maybe in a postmenopausal woman or menopausal woman, we may not be wanting to, save the ovaries back if we, for whatever reason, have to remove the uterus in that case. So the same way that there may be different medical options, there may be different ethical options also. And so there are different ways of behaving ethically. And one's ethical choice need not be necessarily unethical for the other. For example, we always talk about this pro-life and pro-choice, pro MTP and against MTP lobbies. Both in their right aspect are probably right, and they have their ethical issues with it. So what it requires that we give each principle due consideration and be able to justify the priorities by which we finally take a decision. So FIGO has a huge role to play in all this, because in all aspects of women healthcare, ethical concerns need to be addressed and professionally dealt with. Ethical sensitivity in women's healthcare cannot be overemphasized, as in today's world, still in many countries, including our own communities and religions and social and family settings, women find themselves in disadvantageous status, if not downright subordinates in many cases. So from its inception, the Ethics Committee has made recommendations for guidance of and stimulation of discussion among all practitioners, and particularly for use by member societies to promote broader national and regional discussions of challenging ethical issues. And what we have done, this was during my tenure, we published this particular book, and this book is available on Amazon and also on FIGO website. It deals with 85 different topics in day-to-day practice, how we should decide in a given situation. We'll be discussing some of them today. And for those who are really interested, there is bioethics training curriculum now available on, for FIGO members. And this is also there on FIGO website. So let's come to some clinical issues and deal with them as we go ahead. So when you have to decide on a clinical issue, this 4 boxes method becomes very important. What is this 4 box method, which was proposed by Johnson and Sigler, is that we have to consider 4 things. 1, medical indications, including principles of benefit and harm. 2, the patient preferences, that means autonomy, protection, confidentiality, and capacity to choose. Quality of life, what our patient will perceive as her quality of life after that particular treatment, and context of ethical equation, which involves justice issues, which we'll discuss. So in case of obstetrics, maternal plus fetal considerations will have to be given weightage in every box that we have mentioned above. So let's actually deal with some practical cases in front of us. This Amala is aged 19 years. She comes to you for a consultation and advice regarding contraceptive care. She tells you in confidence that she is keeping sexual relationship with much older rich man who is paying for her education and other needs in lieu of unprotected sex with him, and on the condition that she should not reveal the relationship to anyone. She is upset and restless day and night, and also afraid of becoming pregnant. Now, your ethical dilemma is, should you ethically provide Amla with contraceptive care? Should you respect her request for confidentiality? Should you report her situation to parents, police authorities, or women protection agency? Or what other advice you should give Amla that will be helpful to her other than contraceptives? So these are the guidelines, number 5, 6, 16 in this FIGO guideline book that will come of help to you here. And what are they? They deal with confidentiality, because it's a duty to protect patients' confidentiality. It, especially in young adults and adolescents, is very important that we protect their confidentiality so they have no fear to approach us. Then privacy, of course, is very important, and we cannot, tell about what's happening in patient's life to somebody else without her permission. And sexual and reproductive rights are, of course, fundamental human rights, and sexual life free from violence, coercion, disease, and unwanted pregnancy is important. Sexual autonomy. Individuals have the right to freely choose whether to engage in sexual relationships without coercion and violence. So, how will you assess on this background? How will you assess Amla is an adult where autonomy matters? As far as beneficence and no malfeasance is concerned, your advice will help her. You may additionally advise her regarding STDs, including HIV. And as far as justice is concerned, is Amala's situation to be interpreted as violence against women? And should you take additional step to protect her? Is it your ethical responsibility? What about her sexual autonomy? So you will have to counsel her regarding her actual rights, regarding her what's happening, and then only finally you will have to take decisions. So see, a lot of thinking has to go in, and that's where our guidelines help you. Now, a common situation. Refusal of treatment. A patient is in labor, you advise a cesarean section for fetal distress, the relatives refuse consent and prevail upon the patient to refuse consent. What should you do? Should you respect the autonomy of the patient? Should you take the ethical stand that it will do harm to the baby and hence go ahead and operate? Or what if it becomes obstructed labor and patient's morbidity becomes a distinct possibility, the justice issue? What are your ethical choices? What are the legal remedies? Again, let's go to the FIGO guideline number 8. What does it tell you? Refusal of treatment by a competent patient must be respected, even if the refusal seems irrational or poses health. Informed refusal requires that patient understand the implications of declining treatment, including effects on their own health and dependence. Respectful persuasion should be used to explore and address refusals, but the patients must not be abandoned. That's important. But in our country and medico-legally, I would go one step further and advise that to make it safer, document the refusal properly, either by video documentation or at least written documentation. And also, in some situations, inform the police. But because later on, patient's relative, if something happens to the patient, might renegade and say that we never refused. And so you have to have proof that they had refused the treatment. And of course, in our country, court authorized treatment is not easy, but in European and American situations, they get mandated by the court, and in almost 80% of the cases, the courts have mandated urgently to go ahead with the treatment. Of course, when it's life-saving situation, you can go ahead. Another situation, exactly opposite, cesarean section on request. Nowadays, this has become very common. So Nita, 37 years prima grada, working as an executive manager in IT firm. She discusses with you at 34 weeks the mode of delivery and insists on cesarean section. She does. Her reasons are she does not want any risk to the baby due to labor or delivery, wants to maintain her appearance and bodily integrity, fears for long-term prolapse and urinary incontinence, which she has read on Google. And should you comply with the request? What are your ethical duties if you don't agree with her? And how do you assess that? Should you counsel her about her fears? So how does FIGO guidelines on CDMR help us? CDMR is cesarean delivery on maternal request. FIGO recommends a patient-centered approach to cesarean section on maternal request, emphasizing that healthcare providers should first recommend vaginal delivery and counsel the patient on the risk and benefits of both options. If CDMR is performed, it should not be scheduled before 39 weeks of gestation without other indications and must be preceded by thorough informed consent and counseling about the procedure's risks, including those associated with future pregnancies. And these are the recommendations, very thorough. If you go through that, they tell you exactly what you need to do. What is most important is the patient counseling. Comprehensive counseling is a cornerstone of CDMR management. This includes discussing the reasons for the request, explaining the evidence-based risks and benefits of both vaginal cesarean birth, and addressing any misconception. And of course, then properly informed consent becomes mandatory, and we should not forget about this. Now let's talk about something a little different. Egg donation. Now, this patient, Mrs. Shinde, she is infertile patient, comes for IVF, but she cannot, actually afford the treatment. But she knows a 39-year-old lady who requires an egg donor, and so this Mrs. Shinde is ready to donate her egg for her in lieu of getting the cost of her treatment herself. So can you use such compensated donor for treatment? Both will be benefited. So should you use the principle of beneficence in your consideration? Can you maintain confidentiality of both of them? What about anonymity and what about the legality? Again, there is a FIGO guideline detailing us about this. Now remember, this FIGO guideline is an international guideline and it considers the ethics of the situation, right? So that's why it doesn't say that you do not use that. You can, in given situation, go ahead, but you have to balance the privacy and autonomy of the patient. And so in conclusion, the FIGO advocates for global standardized ethical and equitable gamete donation practices, emphasizing informed consent, safety, privacy, and respect for cultural diversity. Long-term follow-up and international cooperation are essential to ensure the well-being of all parties involved. But in India, we now have ART law, and it covers gamete donation in details, which mandates donor eligibility, it mandates anonymity, and so all these criteria. So whenever a law is there, it always prevails, and that we must again remember when we are talking about ethics. If you feel that ethically you are right, you need to change and advocate to change the law. Now, this one particular guideline on menstrual health management is something I'm particularly proud of because I insisted and brought it in the being in FIGO, because we know that in our situation, the girls in the community really suffer during the menstrual period. They miss their schools, and they feel distressed. They cannot, they're isolated during that time in many communities. So we created this guideline, and what this guideline tells you, that menstrual hygiene management has been defined as women and adolescent girls using a clean menstrual management material to absorb and collect blood that can be changed in privacy as often as necessary for the duration of the period, using soap and water and washing the body. This appears simple, and given, but it's not so in many communities. And that's why FIGO has always held sexual and reproductive health rights of women around the world as a high priority issue, and MHM is an important ingredient of SRHR because it has a huge impact on the development of the life of girls, women, not only in health, but education, security, and gender equality. So we know that in many low and middle income countries, the safe, clean water is not available, the adequacy is not available. So what do we do? The FIGO recommends, and this is our responsibility, that MHM is a concern not only for women, but for women and men equally, and for societies. FIGO member societies, and this is where we forget that FOGSI as a FIGO member society has a different role in ethics, should invoke the ethical principles of beneficence and healthcare justice to advocate for the development of coordinated health policy by all levels of government to support the development and implementation of effective MHM programs. That means, as FOGSI, this is our responsibility, that when we need to change the policies of the government for the benefit of women, we should be going after that, advocating, lobbying, and convincing the powers that be to change the policies and make such things available for our women. And that's why this particular MHM guideline, I feel, is very important. Another, and probably one of the last ones that I want to talk about, is the cosmetic surgery, which is coming up now in a big way. FIGO already has a guideline on this. And look at this patient, a young adult girl, Ria, in good general health, wants to reduce size of her labia minora. She expresses dissatisfaction with the natural size and shape as she is getting married, and she wants the surgery to align with her body image and goals. And she has, read on Google and all that it can be done, and that improves her impression with maybe her partner, and so on. What does the FIGO guideline say? It's about cosmetic genital surgery. Cosmetic genital surgery involves altering vulvovaginal anatomy for aesthetic reasons in women without structural or functional abnormalities. The guideline highlights the growing demand for these procedures driven by societal pressures, media influence, misrepresentation of normal anatomical variations as abnormalities that we see commonly. It emphasizes the lack of strong evidence supporting the safety and effectiveness of these surgeries, including laser-based devices marketed for cosmetic purposes or treating genitourinary syndromes of menopause. So the key ethical considerations here are autonomy and informed consent. Women must be fully informed about the risk, lack of medical necessity, and societal influences affecting their decisions. Non-malfeasance. Physicians should avoid harm, including physical complications and psychological distress, and prioritize mental health support for conditions like body dysmorphic disorder. Justice. Cosmetic surgeries can reinforce unrealistic ideals and widen health disparities due to their high cost, because they may not be available to everyone. And for adolescents, they may lack the maturity to make informed decisions, and their developing bodies pose unique risks. And so FIGO recommendations include counseling the women about natural diversity of genital anatomy, ensuring surgeons are properly trained, identifying underlying mental health conditions, and discouraging misleading marketing practices. And finally, it says that FIGO asserts that it is ethically inappropriate for obstetricians and gynecologists to recommend, perform, or refer patients for these procedures due to insufficient evidence of their safety and efficacy. So see, that's something that we have to ponder about what's happening around us. And finally, and this I may be approaching in the next panel discussion a little, so I'll finish it in very short. The 25-year-old primigravida, 25 weeks pregnant, comes with symptoms like this, almost severe early onset preeclampsia with HELLP syndrome-like condition. Now, it appears that we, in this situation, have no choice but to terminate the pregnancy. Then what do we tell the couple about the baby, what they should be doing, because it's a peri-viable situation here, 25 weeks. So what is the guideline of FIGO about peri-viability? Viability? The document discusses the ethical and practical challenges of parental care at the limit of viability, focusing on the gray zone of prognostic uncertainty for extremely preterm infants. It emphasizes that gestational age thresholds for viability vary globally due to differences in resources, and decisions should be based on the peri-viability interval rather than arbitrary limits. Ethical principles such as beneficence, non-malfeasance, autonomy, and justice guide the decision-making, but interpretations differ due to cultural, socio-economic, and religious factors. So we have to deeply consider all this. What will happen to the baby? What cost is going to be there for the family? What if something goes wrong later on? So this has to be discussed in details. And so the key points here are decision-making is complex, and with disagreements offer between parents and physicians. Counseling plays a critical role, requiring personalization based on fetal, maternal, and parental factors. Decisions should ideally be made before birth, avoiding reliance on the newborn's appearance at the delivery. So, see how the FOGSI committee, when the experts sit together, many of us, every detailed discussion, including legal, ethical, goes into. Every word is weighed properly before putting it into the guidelines, and that's why they are so good, and that's why we should heed to them, because they are not just any discussion points, but they have been arrived after a lot of discussion, lot of references, and so on. And finally, we come to the the discussion points regarding maybe the next panel. This will be useful. So 37-year-old couples comes with baby. They've undergone treatment for infertility, but now they have a baby which is bilateral lip and cleft palate. The couple asks for termination of the pregnancy, fearing that some residual damage will be limited. What would you do? And let's discuss that. And in the panel, these are the questions that will be raised for this couple. Then who are we responsible for here? Are we responsible for the mother, or are we responsible for the baby? Suppose you have a patient who has cardiopulmonary anomaly like Eisenmenger syndrome, whether when she's likely to die if pregnancy goes on till full term. Then what do you do? As a for a benefit of the fetus, you may want to prolong the pregnancy as a fiduciary to the fetus. But what about your responsibility towards the mother? Whether you advise termination or what happens? So we come to the question, and this is where the panel will start with: what is a fetus? Is it an unborn child, or is it a patient in utero? If we call it unborn child, then it should have all the rights of a child, like full-fledged adult person. If we call it a patient, then we will have to be in fiduciary relationship with it and keep the benefit of the fetus in mind all the time. If the fetus is the patient, then what happens to the mother? Is she only the uterine environment, the recovery room, or a natural incubator for the fetus, as has been described by Casper, or worse, reduced to a holding cell that entraps the fetus, or an abdominal wall, a fortress against fetal health care, as maybe some pediatric surgeons would think about? So, what are the rights of this fetus? Right to being born alive, right of being born with healthy life, both mentally and physically, and right not to be born. So let's discuss this in our panel. So in conclusion, it is easy to see that medical technology has expanded exponentially, and with that we face more complex ethical questions in practice. Medical knowledge alone cannot help us solve these. Good decisions in these areas depend on thoughtful consideration of values, interests, rights, goals, and obligations of those involved, all of which are the concern of the medical ethics. And learning the formal discipline of biomedical ethics and structured analysis can facilitate the resolution of ethical problems, and that will give us confidence that whatever we are doing, we are practicing ethically and doing good by the patients. So thank you very much for your kind listening.
Thank you so much, Sanjay. I think the entire thought process is going to flow in very seamlessly into the next round of panel discussions that we are going to have. But before that, just 2 or 3 questions, which are, it's a very large audience today, about 300 plus in this forum, but many, many more hundreds on the YouTube who are seeing this directly. So this has really caught great attention in this era of many webinars happening everywhere, and even with single-digit attendance, the faculty is raving to go. That's what is the general scenario, but we are good today with a large audience. So one simple question from Dr. Hemant Bhatt: is it necessary to take consent of both the husband and wife for MTP?
For
pregnancy termination.
No, for pregnancy termination, the consent of wife is good enough. That's what the MTP law says. So husband consent is not required. Having said that, whenever possible, you may take husband's consent, if possible, as a witness, so that later on, sometimes divorce proceedings come up, and then the husband blames the patient and the medical personnel for doing MTP without knowledge. To that extent, in worst case scenario, that I had to defend for one of our colleagues, the husband alleged that it was the affair between the patient and the husband, the patient and the doctor, and that's why they did not take his consent and did that. So in our country, everything is possible, and we have to be little careful. But as far as the laws goes, even if she comes alone, if she's an adult, and if she gives you the consent, you need not worry about whether husband agrees or not.
Right. And then you also mentioned a point about the alignment with recommendations, to fall in line with the standard practices, and that's to be viewed as ethical. But the flawed, recommendations which do not fit the country context, the complex group of the professional body saying one thing or the other, and the practitioners really not paying attention to what the protocols are for. So how do you address that?
Yes. The ground realities do differ, and that's where I think our organization has to play a role. I think ethics is something we need to work on, and all our guidelines that come should have these ethical aspects in mind, because then only people are going to follow it. Because if they don't follow and if they have a case against them, then naturally if they are not following the guidelines, they will be in trouble. And that's why in all our guideline making, we have to consider the ethical aspects of the situation also. Of course, ground realities are different because our context is different as far as periphery, villages, what are the availabilities there, all this. So in our situation, the guidelines has to be complex. It has to be given due consideration and lot of deliberation, and contextually changed depending on what is available at ground level.
So thanks, Sanjay. There's just one last question. You mentioned the gray zone of viability, 25 weeks, but there is somebody who is asking, even beyond that, 28, 30 weeks, where you're rather hopeful that this baby should pull through, and you are putting the perspective in a positive way to the parents who are in private hospital.
Correct.
Okay. Then actually the stay gets prolonged, and then halfway through, then you raise your hand saying that it still needs about 4 weeks stay, and then put it on to a public hospital because the patient cannot afford it any longer in the place. Then the patient says, I never knew it would take so long, and this shift over is really not. So where does that
Right.
what do you do?
So that's where that guideline says that all this discussion and counseling should happen before the delivery. And they have to be given a true idea about what is the possibility of survival of the baby, what is the possibility of the healthy survival of the baby at that, and what it is going to cost them when the baby has to be on ventilator for maybe 2 months or 3 months. Right now, we had a patient, a very precious pregnancy with twins, couldn't afford it. So we had done everything at concession level. She started leaking at 26 weeks. We took her somehow till 30 weeks. But after that, we had to deliver her. The cost to the patient in NICU, which is, one of the good hospitals here, NICU, that Dinanath Mangeshkar Hospital, cost them 20 lakhs rupees. The hospital was good enough that they realized the whole situation the patient was really not affording, and that's why they wiped out all the charges for the patient, and patient went home with the live baby. So these are the situations. There are some trust which help in this situation. All should be explored before, and patient should be made aware of all these issues.
Sure. In the interest of time now, I think the audience has begun thinking, and there are plenty of more questions coming up. One question from Dr. Sanchita Dubey. As regards the C-section on maternal request, just a consent that she has been explained the risks is enough, or is there something more that we need to add to the?
I think just like we have now, consents for all the surgeries, the consent for CDMR is also required, where what we have explained should be there on the sheet. That that I mentioned in my talk, and that's there in the FIGO guideline, that what we have told her should be mentioned, and then the consent should be taken.
Right. There are two questions from Dr. Mrutyunjay Barlad, and that will be really the last before we jump to the panel. One is about if the woman has undergone MTP without information to husband, it is a ground for divorce, is what Bellard believes in. That is one thing. I don't know, it's just a comment that he's made. And another question is, if the periviable baby is delivered and stillborn, what should be done if the what should be done with the baby if the family members refuse to take the baby?
Okay. The first, even if the MTP is done without husband's consent, it itself cannot be ground of divorce. If any
Yes.
court says
The
that,
angle of women's right, her body, her mind.
correct, because that goes against the MTP law,
Hmm.
which is not the same for sterilization operation, mind you. Because in one of the cases of sterilization operation, when sterilization operation was done, without letting the husband know, the husband went into Supreme Court with saying that it's a cruelty against him, and the Supreme Court unfortunately has agreed to give divorce. So sterilization is different and MTP is different, because sterilization, there is no written down law. That's one thing. Secondly, if the baby, is
Abandoned.
a stillborn baby, first of all, hopefully the consent and all for that delivery would be there. And then it depends on, if the baby is less than 500 grams, can be disposed of in other ways, like an MTP pregnancy. But if it is more than 500 grams, then it will have to be handed over to the authorities, saying that this is the situation, this baby is stillborn, and like any other, even adult, they don't take the body, or to inform the police that, this body is not being taken.
And I think this MTP beyond 26 weeks, baby survives, kept in the NICU. No one wants to take onus on that. That is Jyotika's comment. That maybe we'll respond to that. And Chinmay, if we can bring this point up somewhere,
Yes.
about what to do with, halfway, neither here nor there. That's a dilemma in itself.
Let's discuss it in the panel. That's an interesting
Yes, so that's why I'm just requesting Chinmay to take that over in the panel. And if Dr. Gupte can wait on and be an expert on our panel as well, it will be much appreciated. And there are many, many more questions which are pouring in, but we will have many more webinars, because a dilemma today for me is to continue the Q&A or get on with the next panel discussion in the interest of time. I think so. We will move on. Thank you very much once again, Sanjay. And we move now to the panel, and I would hand it over to Dr. Purni to introduce our brilliant panelists.
I'm also looking forward to listen to these really great people that are there.
Absolutely. Yes.
So we now move on to the case-based panel discussion on ethical dilemmas and decision-making in high-risk pregnancy. This panel will be moderated by none other than Dr. Chinmayi Ratha. She will be moderating the session. Dr. Chinmayi, welcome to you. She is the Director and Lead Consultant at the Resolution Center of Fetal Medicine, Hyderabad, and President of the Society of Fetal Medicine, Telangana chapter. She is known for her exceptional expertise in fetal medicine and her commitment to multidisciplinary collaboration in perinatal care. We look forward to your skillful moderation of today's panel. Going on to the panelists for today's case-based panel discussion. Dr. Ashok Khurana, welcome to you, sir, Secretary of the Society of Fetal Medicine and one of India's most respected names in perinatal
mentor emeritus. He's been the president also. He's the founder of the Society of Fetal Medicine and currently mentor emeritus.
We have to catch up. Yes.
Dr. Khurana has contributed immensely to developing ethical framework and practice standards in fetal medicine and diagnostics. It's an honor to have you with us here today, sir. The next on our panel is Dr. Bijoy Balakrishnan, all the way from Kerala. He is the lead consultant in fetal medicine unit at CIMAR Ernakulam. He has been instrumental in advancing fetal medicine services and education in South India with a special focus on clinical ethics and prenatal decision making. We're delighted to have you with us, sir. Next on our panel is Dr. Sita Ramamurthy Pal. She's the convener of the Fetal Medicine and Imaging Committee and the Perinatology Committee at the Bengal Obstetric and Gynecological Society. Her insights into fetal imaging and ethical decision pathways in perinatal medicine are sure to add great value to this dialogue. Welcome, Dr. Sita.
Thank you.
Last but not the least on our panel is Dr. Bela Bhatt. She's obstetrician gynecologist and fetal medicine consultant, vice president-elect of FOXI as well. Dr. Bhatt is a passionate advocate for evidence-based practice and ethical patient communication, particularly in complex pregnancy care. We are glad to have her perspective today. Over to you, Dr. Chinmay.
Thank you, Dr. Purni. And at the outset, Hema ma'am, thank you so much for this opportunity. And I'm particularly grateful that you've given us a topic which is very close to our heart. And you've given us people who are just out of the world. There cannot be a better panel than this, who can address all the issues that Dr. Gupte has so skillfully laid out to us, because it started thinking, most of the times you have more questions in your mind before a lecture, and a lecture answers all the questions. Ethics is one topic where you have so many questions after the lecture, because the whole process starts building up in your mind once you listen to the facts. So ethical dilemmas and in decision making. A doctor's dilemma is well known. It's always to do or not to do. And Sir has just laid out the core principles of medical ethics, where there is autonomy, there is justice, there is non-maleficence, and there is beneficence. And with our, component of evidence-based care, we have to make sure of all these things and take decisions of to do or not to do. Never make a mistake, always do the right thing. But how easy is it to do the right thing? So in fetal medicine, we are a lot of fetal medicine experts here, so there'll be a lot of discussion around fetal medicine. We keep on talking about fetal scans, fetal screening, everything like that. And then you have come up with better screening for aneuploidies, better anomaly checks. So every day a patient comes to us. Her name is Mrs. Everyday. She's a primi gravida, 24-year-old, 6 weeks gestation, everything fine. And then she comes to you for her regular antenatal care. Hema ma'am, you're the top person in that panel as an obstetrician, and everybody goes to you first. So she just comes to you at 6 weeks of gestation. Everything is good. What would you tell her about fetal care now?
See, always our tone is by default reassuring, because this is an era where there's a lot of anxiety that can be seeded into the patient's mind, because that is already, the entire family, especially depending on the background of the pregnancy. So we have to, first of all, make sure whether she's on preconceptual folic acid. If not, at least start the folic acid, vitamin B12 combinations that time. And then we would guide her for many questions that she would ask about her the diet and daily activities, etc., because everybody is walking on a tight rope. And so far, so good is what we would tell her. And because she's a primary, she doesn't have any other background where I need to call her at a very high frequency. I would keep the standard about 3 weeks or so for her next visit. And
is everything okay? I'm absolutely fine. I didn't start folic acid, madam. Is it okay if I start now?
Yeah, because at the earliest available opportunity, yes, you should start. And we will also advise a couple of investigations which are routinely done in the antenatal.
About the fetus, when will I know that this baby is all fine because I didn't take the folic acid before pregnancy?
That will be difficult to say, because the neural tube defects are the one which we expect if somebody who is not on folic acid. Having said that, because many pregnancies in our own country are unplanned, we would not threaten our own minds and your mind so much that you would have a neural tube defect. But in the era of high resolution machines that we have, there is a possibility that if such a defect which we are expecting exists, we would be probably able to pick it up earlier rather than later. So we will see how it goes.
So when do you want to see my fetus, ma'am, for everything else? When will I know that the baby is doing well?
No, if she has no symptoms, also 3.5 weeks is the next visit that we would call her, and certainly around 11 weeks to 13 weeks when we are calling her for the NT, we would also extend it to a particular look at it. And we are not, Chinmay, very particularly worried about a patient not having taken her folic acid. This is a very, very common scenario across the country. So we know that it should have been given right from the preconceptional stage, but as if to say that history alone that she has started folic acid at her 6th week of pregnancy will not, escalate the review of the fetus beyond the norms.
So for the norms, what do we want to ask her for next? Maybe I'll go to Dr. Bela. Now, do you want to ask her something for fetal care? What is the next that you want to see her?
So basically, if the patient comes to me at 6 weeks of gestation, I would always give her an option of an early pregnancy scan because I would like to rule out the ectopic pregnancy.
That is all done. She has a 6-week scan, single life fetus, average for gestation age, good fetal heart. What is the next? When do you want to see the fetus next?
Then at the next scan, I would certainly advise her. I will tell her that there are two very, very important scans that she should not miss in pregnancy. One is at 11 to 13 weeks window. That is a nuchal scan. And the second one would be the second trimester.
So 11 weeks you want to see her next. What is it? Right? Why do I need that scan, doctor?
Because we know that this is 11 to 13 weeks is the golden window where I'm going to look at, of course, dating, which is very, very important. I'm going to confirm the dating based on that scan. I'm going to look at whether it's, we have already confirmed singleton. Okay. So we are going to look at the markers for aneuploidy. I'm going to have a look at the structures of the fetus because I can rule out many of 40 to 50% of major structure anomalies. We were discussing about neural tube defect. In case patient has not taken peripartum folic acid, we can also pick up some of the neural tube defects with the primary looking at the spine as well as some secondary signs in the brain, though not all open neural tube defect, but some of them can be picked up. We'll also have a look at all the structures of the fetus. A very important aspect is the screening for preeclampsia and fetal growth restriction by looking at the mean uterine artery PI and combining it with the maternal.
So there's so much that can be done in first trimester. Dr. Sita, should we offer this to everyone? Does everyone need screening? Can a patient refuse that I don't want to do all this? This is all sounding very daunting. I don't want all this. Should we offer this to everyone?
Absolutely. I think we need to offer it to everyone because firstly, it is available now and the screening is mainly to pick up that high risk and the low risk population. So when we have it, I think we will be doing injustice to the patient if we don't tell them about what is available and offer them. Of course, it is her decision. She has the full right to accept it or decline it. But tomorrow if she comes and tells you that, doctor, you never told me that this thing existed and my friend had this or this something. I think whatever is available, it is our duty, our responsibility to tell them what is there, what are the pros and cons, what are the, how much can we detect, rather than putting it in a very intimidating way. We can tell them that this is what is available and then.
But you want to do so many tests. So, sir, Ashok Khurana, sir, this is all this new generation talking. They have so many tests that they know of. They have read so much that thing. But this is from your times that, when we started the human race, the era of medicine started early, and the whole purpose of medicine was to reduce human suffering, and it was an art of healing with the idea of do no harm. So this journey of the fetus has become very daunting, and are we making it a very hugely medicalized traumatic experience? Khurana sir, is it ethical to talk about so many interventions to a pregnant woman and then perhaps convert her low-risk pregnancy into a high-risk pregnancy because there is no prospective definition of a low-risk pregnancy and we are looking for something to do in a high-risk pregnancy?
Wonderful. So 3 things that we must consider here. A, that the only constant in human evolution is change, which is why evolution takes place. So there is the philosophical approach to this. The second is, are we converting a natural process into a very highly professional clinical process? And the question is, if it is safer for the mother and the fetus, so be it. There is no 2 doubts about these principles. The third question is, who is going to pay for the cost of the tests? What about the timing for these tests? And does anybody have a right to refuse? That is entirely up to the patient. So honestly speaking, there isn't any decision making over here. We offer it because it is available. We offer it because it improves outcomes. And we're not being judgmental. We have evidence for all of this. And then the patient decides whether she wants this or not. And she has every right to say no, and we respect her for it.
If she says no, we just we offer the test. We offer it to everybody because we know that the advantages of doing the test are much more than not doing it.
Exactly.
Yes, there is no prospective definition of a low risk pregnancy, and our endeavor as obstetricians is only to look for that high risk, not because we want to create risk, but we want to identify that risk which already exists and then address it in a manner that will ultimately, like Sir said, make the outcome better for the mother and the fetus. Ma'am, you've raised your hand.
Yeah, Chinmay, what I wanted to say is my opening sentence was you tell her, communicate with her in a reassuring manner. We are not trying to over medicalize and bombard her with baby. So that is why the key to this entire deliberation is also communication. Whether she's understood why the screening is necessary, she may just refuse because she just can't make any sense out of it. And when you say one side of the coin is over medicalization, but as Sita said, what is there we have to offer, but the tone of deliberation, because everyday patient you're talking about, and every day we cannot scare them about everything that can happen, but the
And
caution.
this is what happens, ma'am. Like when we talk to her, when Mrs. Everybody is explained all these things, this is her reaction. Why are you telling me all this, doctor? Is something wrong? My sister had a baby 2 years back. She was never told such things. What is wrong? Is something wrong with me? She starts crying. That is the usual reaction. So like you said, the answer to this
cannot be
is
the usual reaction. Everyday
no,
patient, we cannot have them like this. Chinmay, please.
unless we do that. What you actually said as your first statement is something, an important statement for everybody to understand, that we are not here looking for risk because we want to convert every pregnancy into a risky pregnancy and call ourselves high risk obstetricians, but the fact that there can be risk and that has to be explained. So instead of her going this way, you should know how to talk properly, how to
Absolutely.
explain things properly, because as you have very rightly said, that's the point we were coming to at the end of it, that communication is the key. And this inability to leave well alone, when we keep on looking at problems, is it that we are turning our direction towards a medicalized pregnancy? Are we unable to leave well alone? I think it's not like we are unable to leave well alone, but who is well and who is not well, we will not know unless we screen. So the definition of well has changed. It's not that every pregnancy can be left alone. You now know that every pregnancy is low risk unless proved otherwise. So you have to keep on proving the low riskness of that pregnancy and continue to look for things. So when we keep on explaining the patient certain things, they get perplexed, the obstetrician gets distressed. She thinks this screening and all is not necessary. It's an unnecessary waste of time, but that's not the point. The point is we need to counsel properly. We need to talk. And when we talk of counseling, we always think about our talking, but also listening is a part of counseling. And we must understand what they any test that we offer them, we should explain why we are offering the test. Should they opt or not opt is their decision. We'll respect that decision. But after the test is done, what is the result and how we will move forward with our decision will be part of post-test. So now we've understood, we will not scare people routinely. We will just tell them whatever has to be done. So it is not unethical to tell them about the tests, because like Dr. Sita said, if the test is available and there is a possibility of knowing what the test is, then not offering it might be unethical. So offering is not unethical. Scaring may be unethical, but that will only be a problem if we don't talk properly and they don't understand properly. So finally, we've got to...
I just wanted to add something. Saying that I've had patients who have delivered sort of around 10, 12 years ago, and they've come with their nieces or something, and they said, you never told me when I was pregnant about all this. And why is it now different? So I said, yes, things have evolved. As Sir Khurana sir said, things have evolved. We never had the mobile then. We have it now. We can't live
now. Absolutely.
So, that sort of explanation and counseling.
And also we can always tell them in very reassuring manner that if we are picking up some high risk factors, suppose like the risk for preeclampsia, FGR, we have a measure to give you that will reduce the risk in the later half of the pregnancy, which would be very good. Low dose aspirin, very simple measure.
So we are looking at problems and possibility of problems, because that is a possibility, and unless we have that forewarning, we will not be forearmed to manage those things. So now fine, she's understood, she's accepted, she's taken your thing, and then she's come. But then one day you have a bad day, and that day you meet a patient who's 24-year-old, G2P1L1, previous child was normal, everything was fine. So this time she decided she doesn't need to see you early because you scare her in the beginning. So she's decided not to come for first trimester screening. She's come at 19 weeks, 4 days. So somebody did the anomaly scan and everything was okay. There were no markers, so she advised the quadruple test. Bijoy, you did the NT scan, the anomaly scan, and you said that she's not had first trimester screening. Please do the quadruple test. Is this necessary?
I think the entire discussion in the first part also revolves around the same thing. There is no need
So
to scare the
you
patient
think it's
at all.
necessary?
No, it's not about seats. It's a thing about when a patient comes to us, we do routine pregnancy screening. If you're going for a health checkup, when somebody asks you to do a treadmill test, it doesn't mean that you're going to have a heart attack. You're doing a routine health checkup. So when a woman comes for pregnancy, for health care, we're going to look at that woman from the perspective of we're doing a checkup for you, and that checkup involves checkup of the mother, checkup of the fetus. So checkup of the mother involves a certain series of blood tests. The checkup of the fetus involves a certain series of scans along with certain blood tests. This is done to see if you are healthy and your baby is healthy. There is no need to broach upon things like Down syndrome or give a detailed history about Down syndrome or give a detailed history of congenital heart disease or give a detailed history of neural tube defects. You can just tell them that we are doing a series of tests and blood tests to pick up the commonest mental retardation disorders, the commonest anomalies that are going to be there, the commonest problems that are going to be there for the baby and a child. When you tell them that, they're not going to think about, I have a problem, or that is why I'm being
done. I think what we all are reaching is that we explain to them the tests in whichever way. All of us have had different ways of explaining it.
The reaction, I think the way we explain is very important. It's not the fact that we have to explain.
And that point is well taken. And now we've agreed that yes, the way we explain is important. Now,
in this case as well, she's now 19 weeks. So the first and most important thing is, as the gestational age progresses, the risk for aneuploidy decreases. So now she's not the same person who was there at 6 weeks or 12 weeks. Her risk has significantly decreased because she has reached 20 weeks. We have done a good scan. We have seen there are no markers. Her risk is extremely low. So when we counsel her, we'll tell her how our starting point should be that your risk for abnormalities is extremely low. However, you haven't screened for the most commonest aneuploidies, and therefore it would be better if you do a screening test for these aneuploidies, because that will tick all the boxes, and that is the standard of care. So if you do that, it's
so you will offer a quadruple test. You will give her the choice of a quadruple test. So you think it is necessary. Now this lady went to her obstetrician and kept telling her.
I would also give them the offer of an NIPT here. Because she has got two.
Yes, I was also going to say the same. Yeah.
She has got two tests here. One is the quadruple test and one is the NIPT. I would offer them both these tests at this point of time. Depending on what
she didn't do either. She didn't do either. She went and kept on asking the obstetrician, Madam, everything is good. Is it necessary? Last time you did everything. Everything was normal. Again, this time, should I waste my money on these tests? Hema, madam.
No, don't encourage too much about last time. Last time ka to last time. It is different era altogether. See, as we said that what was not available 20 years back, and we had mother-in-laws asking questions about even a single scan with a Vishnu. We've come a long way from there.
No, last time she had FTA, she had everything. All the reports were normal. Child is also normal.
Correct. So every pregnancy is different. So every pregnancy needs the same health checkup, as Bijoy said. So she has missed out on her NT and the double marker test.
She
has that is why you're raising the topic of quadruple marker, because she's missed the bus already. So it's fair enough to tell her about, at this point in time, this is the available blood test that we would like to do. Alternatively, the NIPT, which is also surging ahead as a very good.
Ma'am, unfortunately, she didn't go. She didn't come to you.
If she doesn't take it up, then it is. Yeah.
So she didn't come to you, and it was not that you told like this. The other doctor said, it's okay. These fetal medicine people keep on saying so many tests. And anyway, last time I did all the tests that they said, and it was okay. And then when Bijoy had that long conversation with the doctor, he explained that the risk is low at 19 weeks.
Be okay, Baba. But just see, you do the test to prove that it's okay.
Okay. The other obstetrician said how so much handling
I have to do. This baby is going to school now. This baby you see now.
So she said, Madam, I can't come. So the doctor said, it's okay. It's 19 weeks, 4 days. And Bijoy explained that, 6 weeks, the risk was more. 19 weeks, risk is less. Because people understand what they want to understand. So when they understood, she said, it's okay, not necessary. This happens in today's world. The obstetrician says it's okay, not necessary. Fine. Now, things went on fine. At 28 weeks, there was a growth scan. And again, now Bijay is seeing mild prominence of ventricles at 10.5 mm. So what will you report, Bijay?
So now you have mild ventriculomegaly and she has not done any screening. So you will kick off the ventriculomegaly protocol. So the ventriculomegaly protocol obviously involves testing for the infections. We have to test for aneuploidies. We have to do follow-up and see if the ventricle size increases, and we have to do a detailed neurosonogram. Now, this is what we will offer the patient, because now we know 10.5 or 11 is in the region of mild ventriculomegaly. I will also pay particular attention to see if she has developed diabetes during that period of time. If it is a male fetus, also there is a chance of prominent ventricles. So all these things are there in my background.
Doctor, I told that time when you told that the test is required, my madam said, okay, it's okay, not necessary.
What do you say to that? I mean, normally,
what do you say to that?
No, usually, Bijay, we will never blame the patient like that. So for some reason, she's used her discretion at that point in time. Maybe we didn't, convince her, or maybe, she had other reasons to go elsewhere and seek an opinion. That is the distrust we are speaking about. It's fine. Yes. She didn't do. You didn't do. Then again, it becomes a matter of, scare for her. Now what you can do?
What I would
onwards, what you can do, that you tell.
I would usually tell them that, these findings were not there before. And it's possible that this could be just a normal finding. But we need to know now whether something is affecting the child or not. So we need to go ahead. I never asked them to dwell in the past and try to find out what's the solution right now. Even now, I would tell her that the outcomes are extremely good. The baby is otherwise also fine. It is mild ventricular prominence. See, unless it goes beyond 15, I wouldn't say that definitely there is an issue. And I don't know whether there is this progressive ventriculomegaly or not. And I don't know what is causing it, but I need to find out. So if you do the tests and if you do the follow-up, we'll be able to find out what the cause is. And if there is nothing, the child will do absolutely fine.
So all you did was talk to the patient, and that makes a lot of difference rather than playing the blame game. Instead of thinking, why this was not done and that was not done, it makes a lot of sense for us to just, wrap up everything at that point and move on from that level onwards. Many times patients have this habit of listening to only what they want to listen and then retaining only what they want to retain. And then when they recall only what they want to recall. So it's not always what they have listened and what they have retained and what they have recalled. There might be completely exclusive things there. And the obstetrician always remains in the line of fire because it's very difficult for her to keep on, facing the patient as well as the changing gamut of fetal medicine. So in an ideal world, we'd all be speaking the same voice. But if it doesn't happen, always talk, always listen, do adequate pre-test and post-test counseling, choose the best screening test after considering all options. And remember that there will be changes. That, like Sir said, change is only constant. Even in a pregnancy, situations change. So whatever are the missed opportunities, those are learning lessons for the future. But at that point, we have to do crisis management. Never break the law and never criticize colleagues, whatever it happens. So we should remain calm and give our information correctly. Now, there is a 38-year-old primi gravida. She's come for a TIFA scan. She had an IVF conception and she conceived twins. Very happy because 2 failed IVFs in the past. She missed her double marker screening because she was on bed rest because she had some subchorionic hemorrhage at that time. She was advised to take bed rest, so she decided not to come for anything. Now she's come for a TIFA scan and one of the fetuses has a hypoplastic nasal bone. So what investigation should we offer her to rule out chromosome abnormalities, Dr. Sita?
Yeah, so firstly, obviously, we'll counsel her that, we found something and it may not be completely abnormal. A lot of people have this, what exactly is nasal bone, because a lot of tend to think that it is a nose that is absent. So obviously explain to them and then say that it is also associated with aneuploidies and she's not had any screening as of yet. So the best thing is to confirm what is there, and the best ideal way would be to do an invasive test, to do an amniocentesis. And I would
for one baby or for both?
For both. I would test both.
2 pricks.
Sorry?
2 pricks. Double the risk of miscarriage.
But I also want to make sure that the other baby is fine.
Doctor, I have 2 failed IVFs prior to this.
Yeah. But even then, in that case, it
I
is
had that bleeding. My doctor told me to take strict bed rest. That is the reason I could not come for the screening.
Even then, we have found something now that is, may be associated, it may be completely normal, but even then it is our
Became positive and she has twins. Extremely precious pregnancy.
See, there are two comments. One is you have given the option of NIPT amniocentesis. I would want the experts to say also, but NIPT is anyway a reasonable option. No harm to anybody. We may get some information out of it. After all, that is that is one part.
Bijoy, madam is saying
But
NIPT
the other
for
thing I wanted to
hypoplastic
tell,
nasal bone.
no, Chinmay, the other thing, the earlier comment was that she was in bed rest and. In today's era, please kindly everybody, there is help at home, care at home. They will go and draw the blood sample from home. There is so teleconsultations. There are enough number of things you can do in a remote fashion. So you must tell the patient about all these also, so that everybody in the country is aware, because ours is running very fast with the technology. So I think we should exploit that as well. So that was the first comment here. I, as an routine OBGYN, I would be worried for an invasive procedure anyways, because this is all in all, there is a risk for any procedure, even if it's 0.5%, and then could it have been avoided is always the thought running in my mind. And if NIPT...
So the obstetrician always gets the ball, because finally they listen to you. They don't listen to us. So they did off an NIPT.
Add one thing
No, you cannot add anything now. She's already gone to obstetrician.
Vijay, we always ask him to add for our cases. So we should add.
Vijay, wait, your time will come. Wait.
No, just one point on invasive testing. Just one point.
He's bursting my bubbles.
No, just one point on invasive testing. Definitely, when you have an unossified nasal bone in a 38-year-old, you're looking at a high risk for Down syndrome.
Hang on. That's what I'm saying. Just hang on. Just give me one moment.
On both babies having Down syndrome, the risk in a DC pregnancy is less than 1 in 10,000 for anyone. The risk is extremely low that both babies will have Down syndrome. So the point is, if the patient is extremely scared of doing a test, you can tell her that, there is this possibility that one baby may have Downs. The other baby also having Downs is extremely low. So if you don't want to test, the choice is yours. I always leave it to the patient. But if they want to know for sure that the baby has Down syndrome, the best option here would be invasive testing, because NIPT may give us this false illusion that probably these babies are normal, because the fetal fraction of one baby is less. It may come out to be false positive. So here with the marker, I would definitely go in for testing.
And she's not had any previous screening, isn't it? That's what you said.
No,
Yes.
she hasn't had previous screening. We've done the NIPT, and the NIPT has come back as low risk for Down syndrome. So does NIPT work in twins? And now we have evidence that it works in twins. At least for Down syndrome, it works as well as singleton. There is an ACOG practice bulletin which has confirmed this. So it's not a wrong thing to do an NIPT for twins, which we have done. And the way it works is, if both are normal, the NIPT will come back as low risk. Even if one is abnormal, it will come back as high risk. And then we will have to do an invasive procedure. But at least then the invasive procedure is likely to yield a result and therefore justified. Whenever we do an invasive procedure, we do it for both. Now, Khurana sir, these people have all given us lots of inputs. You please tell us, is NIPT enough for a hypoplastic nasal bone? And was it wrong on our part to offer NIPT?
So we're not going to
The
delve
ethical
into...
dilemma.
Yes, the ethical dilemma is very straightforward. We're not going to hunt and kill. What are we going to do with the Down syndrome baby if one of them turns out to be Down syndrome?
Yes, that is the
what
question we
needs
didn't
to
ask.
be must ask her, and would you like to destroy this baby, or would you like to bring up this baby like so many of us bring up problem babies? Question number one, and dilemma number one. The next thing is, yes, very precious pregnancy. Your relative risk of miscarriage is the same as your baseline risk of miscarriage, which in your case is not particularly low, but not particularly high. But we know that the most accurate test in your situation would be invasive testing. But remember, that is also 99.9999 and may not be 100%. The NIPT is a reliable test, but it has its limitations. She should have been counseled about that already. And then let her make up her mind, and let she and her husband make up her mind on whether a Down syndrome baby is acceptable to them or not. And then they will come and tell you exactly what they think.
So one of the first things that we need to discuss with this couple is, like Bijoy said, see, that's why I was saying, Bijoy, wait a minute, because finally the chance of both the babies having an abnormality is very low. NIPT may not be completely enough, but sometimes at least the bare minimum, because she's had no screening. That's what Dr. Sita was alluding to. She's had no screening at all. So at least now an NIPT rules out Down syndrome for us. So we did that. The discomfort that we have is it does not rule out everything else. But should the NIPT also have had shown something? Was she ready to have an invasive test to detect Down syndrome? If that invasive test would have led to a miscarriage of two potentially normal babies, was she ready to accept that outcome? And if we had detected one of them had a problem, was she willing to go and do a fetal reduction? If she was not willing to do that, do we really need to go ahead and even test? So sometimes it's a good decision to talk to them. Are they willing to go the full length? If they are not going to go the full length, then maybe that much of uncertainty we can live with, because it's a very difficult call to take. Any invasive test can lead to miscarriage. And if that miscarriage happens, one of what Bijoy exactly said was the same, that the chance of both of them being affected are very, very low. So here the counseling has to be, sometimes it's a bit brutal to talk like this, but it is sometimes useful because it gives them a thought process till the end. They feel so compelled for the need for testing that after the results they're not willing. I have had this situation once where the patient was referred for an invasive test, and I also did off the invasive test, but after everything, when we got one baby Downs and one baby normal, they said no, we can't take the risk of further risk of miscarriage, because it's okay, at least we know one baby is normal, we'll carry on with both. And I kept on thinking, where was the need for testing? Because if they had anyway going to continue, they would have continued without knowing. But at that time,
I'd like to come in here. That I always tell my patients that invasive is not only for termination; it is also to be prepared of what's coming, and so that they can
so that being
handle the
prepared
pregnancy.
in a non-IVF, non-twins, non-high-risk patient is different. But in a twins, high-risk IVF patient with two failures is a different level of, that is why we are talking about an ethical dilemma here. For a standard singleton pregnancy, maybe I would not go thinking that much. I'd say, okay, let's at least get the information, because one way or the other, we can take a decision. But in this twin, suppose you even detect Down syndrome, that the second part becomes even more difficult to handle. And that is why we put it in the category of an ethical dilemma.
And also, Chinmay, again, Dr. Bellar, he's now hyperactive today. He's telling, in this era, a strict bed rest, is it, is it ethical to bed rest or whatever?
I'm just telling you what happens.
It still happens.
That is an ethical dilemma, whether we should raise a red flag as obstetricians or not.
we are not advising, but please line down. So again,
One point,
the patient's choice.
One point to add. When we are confronted with a twin pregnancy with one baby with Down syndrome, and we have to reduce one baby, of course, miscarriage is the problem if we go in for reduction before 30 or 32 weeks. Now, if you want to reduce the miscarriage risk and only take the risk of preterm birth, then you can actually delay your fetal reduction till around 32 weeks.
Let's hold hold that point later, Bijoy, because that will open up another Pandora's box. Because again, we don't have clarity on that. I'll let Dr. Khurana have his final word on this. Sir, what about late reductions?
So, late reductions would depend on quality of life issues. And we know that in the law of this land, every baby has a right to be born free of abnormalities, and every baby does not have a right to be born. This is something that nobody seems to think. Everyone says that this wonderful Article 31 that we have is that every baby has a right to be born. That is not true. And does every baby have a right to die? That is also not true. But every baby has a right to be born free of abnormalities. And therefore, it is justified if the quality of life issues are to be considered. And then the question arises is that we go by what is legal, or we go by parental choice, and what do we offer and what we let them take up. Now, if there was this situation of another abnormality where there was a risk to the so-called healthy baby, if there was polyamnios that was going to develop and make a predisposed to preterm birth, I would do something. The question is, at 32 weeks, am I going to risk that preterm birth of 33 or 34 weeks for that so-called healthy baby or not? And when is she going to deliver after I do the reduction? Now, here again, the risk perception is going to change throughout pregnancy. And the more she carries on, the more likely she is to carry on and go beyond the 34-week threshold when all of us are truly comfortable, and definitely beyond a 32-week threshold, which is why we talk about 32 weeks. So ethically, we are justified in terminating late, but we do understand that late terminations do also have a problem. And one of them is the effect of potassium on the mother, which we seem to very happily disregard when we do our feticides. There is a risk of maternal cardiac asystole when we do a feticide late in pregnancy. The quantity of potassium chloride has a limit to what we can use, but we shouldn't be using it randomly. We should be using the minimum possible. So these are the ethical considerations that we have to put in mind. We have to make every patient aware of the fact that potassium chloride is not to be taken lightly, and therefore that is what needs to be considered as well. And then let the patient decide on how many babies, which healthy not baby, 2 babies without a mother, and so on.
Because that will open a real Pandora's box in lots of ways. For example, we have other conditions also. There are many twin pregnancies who opt for a reduction because they already have one child. And then if you give them this option of reducing at 32, 33 weeks, and then they go on for that much time, we will have other problems that come up there. So again, any decision we make rationally, we make with the good intent, with that option of beneficence, non-maleficence, autonomy, and justice. But it's not always that it is taken in that forum, and therefore all the ethical dilemmas will arise this thing. She's a patient who's come with a high risk for trisomy 21 on biochemical screening, 18 weeks pregnant, willing for an amniocentesis. She wants a 100% answer, but she's retrovirus positive. If you do high viral loads, and then should we offer her NIPT? I mean, would you counsel her in favor of NIPT? Scan is all normal, or you would go ahead and do an amniocentesis? Is there any ethical dilemma that you have? Dr. Bela.
I think here we have to keep the physician also in the loop, because patient is retrovirus positive. So with the medicines and looking at the viral load and all, then the decision for an invasive can be taken. And of course, till then, the option for NIPT has to be given, which will give us some idea whether it's high risk or low risk. And then we can take a call whether to go for invasive or not. By then, the physician would have taken care of the viral load by maybe titrating the dose of antiviral.
So the physician checked everything and said that the viral load is low, and your NIPT also came back as low risk.
So if the NIPT comes back as a low risk, we have to tell the patient that now the possibility of Down syndrome is really low, because we have done the best screening test possible for Down syndrome, and then let the patient take call.
He was willing for an amniocentesis. You did not let her have an amniocentesis.
No. We gave the information to the patient that there is a possibility that if we do it, the procedure, invasive procedure, now there is a possibility that we'll be transferring the virus to your baby. So it will be increasing the risk to your baby.
So suppose some patient comes and they opt for NIPT versus amniocentesis, you always tell them that we lose out on all the other information when we do NIPT. Amnio gives us the advantage of knowing about all microdeletions, duplications, everything. Here, if the physician's report is okay, fine, she's good for an amniocentesis, would you still err on the side of caution and do an NIPT, or you would offer her an amniocentesis?
A green flag from the physician, I would, and if the patient wants invasive, I would go ahead with invasive.
Everyone thinks the same, all panelists, no ethical dilemmas here?
No, for me here, there's just biochemical screening, and she's a 28-year-old, and just with biochemical screening, I wouldn't think of invasive right now. I wouldn't trust just biochemical screening.
Okay, suppose it's combined screening.
Okay, if you have combined screening tests, and if it has come as 1 in 126, it will still be in the intermediate category for me, because for me, above 1 in 100 is the intermediate group, and I would offer NIPT. Now, if she was 1 in 100, less than 1 in 100, or less than 1 in 10, or 1 in 5, then the chance of microdeletions are going to be high, as you rightly said. So in those cases, if her viral load is low, I would definitely go and test. I would tell her that there is this possibility because you are in that high risk group of other, but only after doing a scan and making sure that there are no other markers or things. But otherwise, NIPT is a very good test here because it prevents us from doing an invasive test in this, unless you have this unique case of combined test positive, greater than 1 in 10 risk with markers on the scan.
We don't have a lot of evidence in this category, but it seems like a reasonable test to do in. So I would just like to ask, like, we have kind of made it a unit protocol. If there is somebody retroviral positive, we offer them NIPT as the primary screening to avoid this situation. So does that make sense, or anyone has ethical dilemmas there? That
I have a major dilemma here.
Yes, sir.
And that is, so what if she's HIV positive? What's going to go wrong with the amniocentesis? We're going to use precautions for the procedure.
Yes.
And that's fine. So whether she is HIV positive or she's Hep B positive, I'm still going to use the same precautions that I would use for everybody. So
But in Hep B, again, we don't have a method of preventing mother-to-child transmission.
Yes, of course. But that's all right. Because the point is that whatever is going to happen is going to happen. But I'm not really worried about the rest of the story. That I will not say that your being HIV positive is going to let me reconsider amniocentesis. If you wish to have one, you can have one. And it has a greater, it has a risk of miscarriage equal to your baseline risk, but it's a more accurate test. And NIPT is a screening test. And if it's okay with you, then we go ahead with an NIPT.
But if she's Hep B positive and we have no method of preventing mother-to-child transmission?
Yes, but that's all right also, no? Because then the baby goes its own way, but at least it won't be Down syndrome with Hep B positive.
So if we offer NIPT as a primary screening test, we are reducing the risks of false positives.
Truly so. But the fact is that the two things really, why should we connect? Because she'll get over the Hep B somewhere along the line, and she'll get over the HIV somewhere along the line.
So there is a dilemma and there is a difference of opinion amongst experts here. Yeah. So this has to be, again, one-on-one judgment call with the patient and the consultant.
And patient to decide.
So now multiple pregnancy, IVF pregnancy with DCDA twins, and one baby, twin one on NT scan has a hypoplastic nasal bone and an increased nuchal translucency. So what investigation should we offer here? NIPT or amniocentesis again? Hypoplastic nasal bone and increased nuchal translucency.
Clearly an invasive testing.
Even the evidence that you showed on NIPT on how it is effective in twins is only for those twins that do not have markers on scans. So if you have a marker on scan, then the efficacy of NIPT has never been proved or tested because always invasive test is better. So if you have an unossified nasal bone or if you have an increased nuchal, the chance of NIPT working in favor of the patient is extremely low. Invasive testing is the way to go.
I'm sure all four of you will say the same. Hema ma'am, she comes back to you and says, I just cannot think of having a miscarriage. I want a non-invasive test.
No. Whichever, no. If NIPT is not going to give me any clue about anything, even at the small risk of miscarriage, I have to counsel the patient that way. That, this is a better option for you is what we would say. And we are again and again coming back on putting more dilemmas into patient's head because finally she'll say, you decide. That's exactly what you told earlier also. So we are in a dilemma, but, as an OBGYN, if NIPT in any circumstance, not specifically in this case, Chinmay, but in any circumstance, if we have an expert opinion that NIPT is reasonably a good test to do and it can give you the answers, of course we will go for NIPT. Because even the smallest of the risk, if amniocentesis is not faring any better than NIPT, then why should I take even that smallest risk? But in certain circumstances, when cases like this, when there is grossly, you are suspecting something and NIPT is likely to miss that, then you're simply offering that instead of offering, then you tell her that amniocentesis in this case would be a better option for the way forward decision making. So there is a small chance, but we take that chance. So that's how I would.
So she didn't listen. She didn't listen, and she went ahead and she
All
just
your
gave
patients
an
are not listening,
NIPT.
Chinmay.
No,
That is not correct.
no, ma'am,
Every
I see
patient
more.
is not
I
listening.
see more patients than what I put here. The ones who listen to me have crossed the stage of ethical dilemmas. You wanted me to put only the dilemmas here.
So one
I see
one
more.
point to raise here is whenever you do the ultrasound, just as you said, talking helps a lot. One phone call to the obstetrician that this is what I'm offering the patient.
Oh, even today I made phone
Yes,
calls to
because they-
obstetricians. They always don't work. But yeah, I agree. No, ma'am, you asked
Helps.
me for dilemma cases. That's why I picked out all the difficult ones.
We respectfully, we respectfully concede to the expert opinion of fetal medicine specialists, all
I
OBGYNs,
wish
because
all
it is getting more
obstetricians
and
were
more
like you.
complex as the
But
days go by. Because there are
Again, we have
so
the same
many
question
multiple things
comes.
thrown in many cases that we really want to, we know that there is beyond what the routine OBGYN knows, and that's why we seek the advice, even to explain to the patient in a convincing way. We have to understand what the problem is, because sometimes it just gets pushed under the carpet because we just want to kind of dodge and avoid because we don't know really what to do. So routine OBGYNs, yes, the phone calls, you persist in the phone calls. We are here to take the expert advice and then go by it, and also tell it in the manner, our whole tone of talking to the patient will change when we are convinced with whatever the experts are saying, if we have the trusted experts like yourselves. I think that was
thank you for that, ma'am. And in fact, 98% of my practice works like that.
Yeah.
You asked me for the ones which are the difficult and the ethically dilemmatic cases, and I pulled out those ones where we really had a lot of back and forth counseling, and
Sure.
people did things which were not exactly what we would have done rationally thinking, because the decisions were driven by conditions beyond our control. So, and especially when the patient says no, you don't know what to do, and when they choose another test which is not the optimal test, again you don't know what to do. You hope for the best. So in here also we thought last time we did it and maybe it would be normal, but here when they did, they found trisomy 13, high risk for trisomy 13. Now high risk for trisomy 13. Bijoy, we had high risk for trisomy 21. That's what we were thinking initially, but now she had an NIPT. It's high risk for trisomy 13 with IVF. And the only thing that we found at that point was, of course, a little increased nuchal translucency and the hypoplastic nasal bone. 16 weeks by that time we got the report and everything. 16-week scan was showing just normal fetus. The nuchal fold had also become okay, but the hypoplastic nasal bone continued and rest of the baby was normal. What should we do?
Definitely, we have to do invasive testing here. And trisomy 13 without a sonographic handle is extremely unlikely. But all the same, my worry would be to not just test for trisomy 13. I would test for the whole series of tests that are involved with increased NT. So I would definitely do a microarray, and the test that we currently use is the Exome Plus or the Exome.
Agreed.
Yeah.
Now, that whole discussion was there, but then the thing which is looming in front of you is a high risk for trisomy 13. So then, like you said, that same discussion happened, that very unlikely to find trisomy 13 in an abnormal baby. And then they also said that that's okay. I mean, since it is no, we'll just continue. They continued. They did not do any test. No invasive test was done in this patient finally. She delivered at full term, and this particular baby, which was abnormal, was also normal at birth. At least at birth, there was no trisomy 13. So at birth, the things are apparently okay. Now, what happens if this baby has some kind of developmental delay that sets in later? Because even at birth, should we now tell them that, at least now go ahead and check for the genetic conditions that you missed? Because in an ideal setting, you would have done, no? You said that you would have done way beyond that, because increased nuchal translucency can present with genetic problems. So you would have done the Exome Plus if they had agreed for an invasive test at that point.
Yes.
They didn't do. They continued the pregnancy and they had twins. And this baby, which had the absent nasal bone, was happy. It was born as a nice baby boy, and they were actually very thrilled that this baby is a boy and everything is fine. They come and show you the baby. Can you be happy for the baby, or you want to still suggest
No, no,
tests?
no. I would be absolutely happy for them. And I would also ask them, the pediatrician, I'll inform the pediatrician or the neonatologist who's in charge that these were the findings that we had seen. So he will pay particular attention on this child to see if this child is showing any signs or any clinical handles for any genetic syndrome. Otherwise, it may miss his notice, and then the child may turn up at a point where no
So when
intervention.
they come to show you the baby, you will tell them this,
I would
that,
tell
you
them.
know,
No, I would tell them.
keep a track. This baby might have
No, no, no,
developmental
no, no.
delay later.
I would tell them that NIPT is notoriously known to throw false positive results for 13 and 18. And the screen positivity, that means the OAPR for trisomy 13 is less than 20%, which means 80% of the time with a positive trisomy 13 on NIPT, the child will be normal. So you were extremely lucky because you were in the false positive group. But we had no method of saying that unless the child was born. So I would reassure them that, but I would also inform the neonatologist that we have seen this. So, but I will not tell the patient. I will tell the neonatologist that this is our patient. This has happened. Please be a little bit careful when you are calling this patient back for follow-up.
So is that okay, Khurana sir? Is that okay to feel scared, not tell the patient, only tell the neonatologist?
So first we have to figure out about trisomy 13. As Bijoy very
sir.
clearly
That's
pointed
not there,
out,
huh?
NIPT was done
wrong.
for something else, and it was a false positive, and the babies turned out to be non-trisomy 13.
But she also had
question
increased
is,
NT, and that was not tested.
therefore, it might be worth it with this increased NT to follow up this baby, and the recommended time is 2 years. And exactly as he says, that we need to be careful because there are many correctable things which we would like to correct at the right time. So let's not miss out on those opportunities. And we must speak and let your pediatrician know what's to be done and decide whether you'll be handled by a counselor or you'll be handled by a pediatrician, and whether you need any early infant intervention in case something shows up.
Will you offer genetic tests now?
Certainly not, because I have no clue, I have no indication for genetic testing.
No phenotypic findings so far.
There is none at all. So if I don't have a phenotype, what genotype am I going to look for?
Hima ma'am?
No, I just raised my hand because I'm voicing out some of the audience questions, which may be really, useful to them to know from the expert. There's so much being talked about NIPT on this panel. So the audience wants to know, there are differential pricing of NIPT in various labs. Is it just for own fancy that they are pricing it differently? Or there are different types or something specific we should ask for, a low priced versus high priced? Is there any difference? What are we as OBGYNs or whoever is referring for NIPT should look into and specify and select the right kind of a test? Is there any difference is basically their question. Why is pricing may be different just for, variety of reasons, but all NIPTs anywhere in any lab is done in a standard way and it all interprets same, or is there any difference is what they're asking.
And the answer is all of the above. So, which is correct, because we know that we started with NIPT, which was very expensive, and then we worked very hard to bring the prices down. And it worked because technology was improving up to a point. But there is a bubble bursting point. And then there are components.
Yeah.
NIPT today is a reasonable test for trisomy 21 and a reasonable test for deletion 22q11 and for none of the others. 13 and 18, ultrasound markers, wonderful. We can even skip the NIPT. And if we find anything on the ultrasound, invasive is the best option. But coming back to NIPT, should I do it therefore only for the common autosomal trisomies? Should I also include the sex chromosomes? Should I include the rare autosomal trisomies? And should I include the microdeletions? What should I do out of these? And therefore the prices can be variable. The true price of an NIPT also depends on the technology. There are two basic technologies, and one is the massively parallel sequencing, and the other is the SNPs. The SNPs is a more expensive technology and therefore will always be a little more expensive test. Out of the rest of it, please understand, every NIPT manufacturing unit is run by private equity. It is not run by the medical profession.
Yeah.
It is an industry for profit. And the basic cost of an NIPT is low. However, it is not lower than the lowest low. And what is happening is that the type of sequencing we do should be done on the correct type of sequencer. So if you dispense with an expensive sequencer and you dispense with the pipeline, you are going to get a very, very wrong result from the NIPT. And on top of it, just to entertain us, they will give a completely wrong cutoff, increasing the number of false positives, because their cutoff rate in that case will be away from that 5% mark and say, okay, I will keep it well below the 100 and I will keep it at 85. And this is all a matter of interpretation and profiteering. So you have to be very, very careful on what you choose and keep your eyes open at all times. And this business of incentivization and private equity has completely destroyed the medical profession.
Thank you, Ashok. Yeah, that was.
Thank you, sir.
Yeah.
So now we move a little bit away from NIPT and reach another, sort of pothole. Again, IVF pregnancy conceived after a lot of effort because it was a unicornuate uterus. And now it's a DCDA twins. So are we happy? Are we sad? Do we want to do something about it? Khurana sir, she comes to you for fetal reduction.
I will start praying from the day I given an appointment. And the risk with a Mullerian abnormality for something going wrong after the reduction and a spontaneous miscarriage taking place is fairly high. The risk of a preterm delivery is also fairly high. And I'm not sure what the size of this horn was before we started out. And I don't know what other risk factors she has, and I presume there might have been some. And therefore, the question is, will she benefit from a fetal reduction? And therefore, should I do it for the prevention of preterm labor? So typically in these situations, I will ring up Bijoy at midnight and he will get a missed call and he will call me back at 5 a.m. in the morning. And he would say, sir, I would do it because this uterus can't take this. That's the answer I'm looking for. And then I will tell the patient I've taken an opinion from another expert, and he feels that your risk of preterm delivery is very high. But, let me see what the cervix looks like. And then when I look at the cervix, I say, okay, the length looks all right. But I have a few other ways in which I can look at the cervix and see what is your risk for preterm delivery. And therefore, in that situation, I will then do additional testing. And one of the tests I like to do in this situation is an artificial intelligence, which depends on cervical texture. Not your standard elastography, but a test which has a commercial name and you pay for it. And it tells you in a far more intelligent way on which uterus is likely to let us down in terms of being a normal length and yet being prone to preterm birth. And therefore, I use that a lot. Beyond that, yes, there is a justified risk. And in that situation, I will reduce the load of this pregnancy on that uterus and perhaps give her an outcome that is a little better.
So in this case, also, there were multiple counseling sessions because of all these things over and over again, because there is really very little, scaffold of evidence that you have here. And whatever evidence, the experience is even more contradictory because sometimes it will work, sometimes it won't. And there are no real factors which will ensure that it will do well. In this case, of course, a reduction was done because the patient was really scared. But having said that, we've had patients who've continued with unicornuate uteruses and still done okay. They don't, like sir said, some of the uteruses are pliable and they can actually reach there. So when we have fetal growth restriction, we all know that we do dating, we find out everything, and there is early onset growth restriction. Now, this is a pregnancy of 24 weeks with a 343-gram baby. Extremely, extremely poorly grown. And you've looked for all these things. This is how the placenta looks like, large jelly-like placenta. Baby looks almost trapped inside that uterus with very little liquor around it. Echogenic bowel, fetal anatomy normal. Now 24 weeks gestational age, uterine Doppler's normal, absent and reversed diastolic flow in the umbilical artery. How frequently should we call her for a follow-up, Dr. Bela?
So this is Singleton you're talking about?
Singleton.
22 weeks, uterine Dopplers normal with umbilical artery increased, raised,
abnormal umbilical artery Dopplers. Now, how frequently should we call her?
First of all, we know that till at least 24 to 25 weeks, it is not the age of viability. So no point in calling before
So
that.
exactly, that is the point I want to come for, because you need weekly Doppler reviews, and also at this point, you have to use your common sense, and you say that you really can't do anything if you call her on that time. So you would call her back after some time. She was already on Ecosprin. You can't offer her anything more than that. You told her. So she came back for a review at 26 weeks, because we gave her a 26 weeks period when at least we can start thinking of viability. So she comes back at 26 weeks, and by that time there is already an intrauterine fetal demise. So did we do something wrong, Dr. Sita, or that was okay?
Well, this baby was, there was a major issue here with the growth. And I think we need to counsel, we would have counseled at that point.
We would have counseled, everything is done. Suppose they just come for a second opinion to you and say that this is what happened. Are you okay, or should they have been monitored more frequently, because that could have prevented the IUFD?
Stenosis was abnormal at that point. I would not have, unless she had preeclampsia or there was any maternal indication to deliver, I wouldn't have delivered her just for a 400-gram baby.
Because ethically here, we understand that whatever we do, we may not be able to have a good prognosis for the fetus till we reach a period of viability, what Gupte sir was alluding to in his talk at that point, that limits of viability need to be defined. And as of now in India, somewhere around 26 to 28 weeks. Actually, most places would go around 28 weeks, but still 26 to 28 weeks is where we would accept. And only around that time we will... Yeah.
I just want to make a suggestion here.
Please do. Yeah.
Yeah. See, when you see a baby at 22 weeks with stage 2 FGR, very bad umbilical artery Doppler, this baby is not going to survive for long. You're looking at maybe 3 weeks at the most that this baby will survive under normal situations if disease is going to progress. But we would be very careful about the mother developing preeclampsia. So in that case, this mother will have to meet the obstetrician very frequently, not the fetal medicine
maternal follow-up should be done. I agree.
Maternal obstetrician, the obstetrician can look at the heart rate. She doesn't have to come for a scan. So you will not miss an IUFD, and she won't come back at 26 weeks. So when the obstetrician is doing the checkup routinely for preeclampsia, she will definitely make it a point to try to listen to the fetal heart rate.
No, are we worried about missing the IUFD? Is it something that is worrying you?
Not miss the IUFD is what I'm saying. Because
if we picked up the IUFD earlier also, what would we have achieved?
We could have reassured that we could have terminated this pregnancy early. There's no need for this mother to carry this pregnancy till 26 weeks to know that she has IUD.
We don't know when she had IUFD. She had IUFD somewhere in between.
Yeah.
So
that's why he's saying she should have come for a follow-up with us, and we would have seen the heart.
Exactly. The fetal medicine person should step back here and send the patient to the obstetrician and say, go regularly to your obstetrician. There is a high risk you will develop preeclampsia. There is nothing that we can do for the baby as such until you reach the period of viability. So we need to see you for a scan at maybe 26 weeks or 25 weeks, depending upon how good your NICU is. But at the same time, meet your obstetrician. You have to meet your obstetrician very regularly. Your BP has to be monitored very regularly. There is a 70% chance that you will develop early onset preeclampsia. So the obstetrician definitely will put a step and look at the fetal heart. So if she's not able to perceive the fetal heart, immediately she's going to send that scan to you. And when you see that person, you will be able to pick up that IUFD much before 26 weeks.
Okay, so let us accept that. Okay, I get your point, what you're saying, but suppose she's just had it, you saw her at 24 weeks or 25 weeks, or whenever she had an IUFD. My point to put this case here was that there is an IUFD happening on your watch.
It is a predicted IUFD that's happening.
That is it. So that is the whole message that we want to give is here. What Dr. Bela said, we don't go by the, we have to follow the Dopplers, because we are getting reports nowadays where people ask for daily Dopplers and this thing because it is absent or reversed. So at this time, when our aim is not to deliver a baby who will eventually live. I mean, suppose it's alive. By the time it comes at 26 weeks, it's still alive and it's still pulling on. Then perhaps we will change our gears completely. But at that point, the dilemma is just to go on. So in FGR, so many things. Yes,
I just want to bring back Dr. Sita's point of the preparedness, because at 22 weeks, we've got such horrible findings that the way we kind of prepare the mind, that any time, she's very close to the gray zone of viability. Even that is a hard zone. Anyway, 24, 25 weeks is also, even if we had some findings and we had to pull it out, and if it was alive also, it's not an easy way forward. So the mental preparedness of this whole family, then when we see repeatedly as OBGYNs and we say, like, we are going to now send you back for the scan because we can't find the heartbeats even, then you all will give us the findings that, the situation has turned from bad to worse and this is where it has ended. And then obviously we will then follow up with whatever we have
just
to do.
Being forewarned is forearmed here, because you just know that this can happen, and it's not like it's happening on your watch, but it is happening in a predictable manner, like you said, and it is something that we have anticipated and we are getting ourselves prepared for that. So treating fetal growth restriction, are there any treatments for fetal growth restriction? Patients, we diagnose it so well. We tell them that this is what it is. They tell you how, what can you do to make it better? So what can we do to make it better? Bijoy, you are the master of fetal growth restriction.
There's nothing we can do to make it better. I think all of us agree on this. That there is nothing we can do to make it better.
Yeah. So when we go by evidence, the answer is there is nothing that you can do to make it better. But again, here the dilemma is to say that nothing we can do will increase her stress further. So we use common sense here. So improved maternal nutrition, by that same holy grail of do no harm. Improve maternal nutrition. It says if mother is malnourished, yes. Otherwise, is there any harm in doing that? Bed rest, hydration, fetal kick count, weekly antenatal checkup, like you just mentioned for that case, because you do that. And then if at all you're following the Dopplers, do weekly, abnormal Dopplers weekly or twice weekly, counsel, prepare NICU and deliver, optimally balancing the hypoxia and acidosis. So at every stage, there is a dilemma because you don't know this is going to work or not work. But sometimes even as a placebo effect, giving some of this helps. Emma ma'am, any points?
No, I wanted to say that we know that none of these are actually working, but in the ground reality is many of the patients come back for a repeated, having been admitted somewhere and having been given some L-arginines and some IV fluids and some oxygen therapy, even lots of things, loads of these things are in reality it's happening, and I don't know how to digest that. And patients do believe that that was the right thing that was done for them. That is even more, upsetting that they have gone through all this unnecessarily, and bits and pieces of admissions, 3 days.
So in that dilemma of not being able to offer,
that's why we want to give a clear message that this really should
that we should not do anything that causes harm, only the things that don't cause harm. And if you advise for rest, it has to be 2 hours in the day and 8 hours in the night. If you advise for hydration, it has to be oral hydration, not IV hydration. And just, a fetal kick count to keep her involved in the process, with a weekly antenatal checkup to rule out any form of maternal comorbid.
There is one question from Priyanka Dubey. She's asking, okay, you all have declared that this case you can't do anything. Can you do something for a similar risk of IUGR in her next pregnancy?
We answered that, that we can do this placental histopathology, autopsy, karyotyping microarray, and thrombophilia screening, and then take it forward. So there are a lot of rational things that can be done, since the panel was all about the ethical dilemmas of situation.
Also, again, Bellat says, Chinmayi madam, please inform in this forum, there is no role of L-arginine and sildenafil. Tell it loudly and clearly.
Absolutely. Sildenafil, there is a safety statement given against the use of sildenafil as a vasodilator in a pregnancy. So that should not be done. L-arginine, there are no evidence-based reports of any help from that point. So we don't give that. Absolutely, sir. So then comes the concept of genetic conditions, because we are also having to wrap up the panel because the ethical dilemmas just won't stop. So now the genetic conditions, we know for sure that you have to have a primary genetic diagnosis. If you have a primary genetic diagnosis, you can offer a prenatal testing. That is all known. So this is a couple who had 2 babies who had different types of problems, and then they had worked up. And when they worked up, the parents were found to be carriers of a particular gene. Both of them had a similar gene, and they were heterozygous for this condition. So it was assumed that the fetus is becoming. So what will be the most reasonable thing to do? She will get pregnant and we will have to do a CVS. So this is what was done in pre-conceptional counseling. So till now we are on. There's no dilemma. Everything is fine. Everybody's on. She comes for the next scan and she's had ovulation induction and she comes with a pentuplet pregnancy. Vijay, I'm referring her to you.
For sure.
For what? No, this is, I mean, it's very difficult. Ideally, what we should be doing is we should be doing 5 CVSs to find out which of these babies are.
That's why I'm referring it to you. Only you can do 5 CVSs.
Only can do 5 CVSs.
Khurana sir.
You know, it's such a tragedy that we are trying an ovulation induction in this situation. It doesn't have an infertility problem.
Yes,
And
true.
so here really is a complete failure of our teaching, and it should never have been done. But now we've landed ourselves in this problem, and now we have to try and get her out of it. We tell her that we are in deep trouble with this pregnancy, but we will try our best. That prayer always helps. Moving to your mother's house also helps. And such things. But the fact is, from a scientific point of view, it is not the easiest thing to handle. Then the question is, should I reduce these before testing? Should I reduce these after testing? When do I do a test? Is CVS better for detecting those DNA changes, or should I do an amniocentesis? In which case, do I wait till a pentuplet pregnancy reaches 16 to 17 weeks of gestation? These are very major problems to handle.
So we waited till 12 weeks thinking that, some of them might have a spontaneous miscarriage, but that didn't happen. And then we went through a very, very difficult sort of counseling where we empirically reduced 3 fetuses at 12 weeks. And then it was very difficult because I told them that you have a 25% chance in each fetus. And it may be that the ones which we reduce could be normal and the ones which we have behind could be problematic. And again, the money involved, because for every test they have to pay. So, and the funny part is for fetal medicine, people will give them concession on their procedures, but the lab will not give concession on the tests. So finally, at 16 weeks, the report was done. It's not an ideal situation, but that's why I put it as an ethical dilemma. So here the outcome was that when we did the reduction, when we did the testing, one of them was affected. However, the couple decided that any which way, if you see the phenotype, those babies were having, eventually they were losing their own viability. So the couple decided to continue, but then they changed their mind and they came back at 20 weeks and had a reduction. So finally, they have one healthy baby. But they had so many procedures in that pregnancy, which was an ethical dilemma for us because it was not easy to have. So then coming to fetal malformations, I'll just wrap it up in one sentence. What will you tell people? I mean, there is an abnormality. You have checked genetics, you have checked everything. The only fact is that this baby will require some treatment postnatally. Should they continue? Should they not continue? All you experts give us one opinion how you will go by it. I have some interesting cases, but then, it'll just take forever because we get carried away in the discussion.
It depends on what malformation it is. Suppose we usually refer to, suppose it's a cardiac malformation, we already refer to a pediatric cardiologist for their, dialogue and counseling to what next to expect and what would they do with this baby, etc. Similarly, for the renal malformation, there will be a step forward that they already, again, it's a situation of preparedness and complete information, which, the place, the cause, the number of settings for surgical interventions maybe, and all of those will need to be comprehensively discussed based on what malformation that's the rational way of dealing with it, ma'am.
This couple has a child with bilateral club feet. We've ruled out everything possible. And we know that it's just bilateral club foot. The father is a physical laborer. And he says that in our community, such kind of a malformation is taboo. If we have one such child, our whole family will get tainted. We cannot afford to have this child. Just to come to show you this baby also, I've had to lose my earning today. And to bring this child again and again for plasters and things like that, I can't do. I want to terminate this pregnancy.
In reality, these kind of requests we do have, Chinmay. We cannot, because there are three buckets of malformations. One is minor, like cleft lip also, which Dr. Sanjay mentioned, and which they can live with it, and then it can easily be corrected. That is one bucket. But you know, they will unreasonably also ask for, no, we don't want. We want a perfect baby. That's the kind
the
of
ethical dilemma.
That they have.
Should we do? Should we not do?
I would like to share an experience here of a father who had a cleft lip and palate, and they came back, and their child is having. He's a successful engineer. He's married well. He's having a good life, but he does not see that. He's seeing the trauma that he faced after having a cleft lip and palate, and he says that his life it's not worth it, and so he decides to go in for termination. I think we shouldn't sit in judgment as to what is right or wrong. We should allow the parent to decide what they want to do with the anomaly, because finally it is their call. They have to manage the patient. We can't take the moral high ground and say that cleft lip and palate is entirely correctable, and therefore we should ask them to continue. We'll tell them these are the chances and these are the outcomes that are available, and post-surgery pictures you can show them. They can meet a maxillary surgeon. Everything can be done. And the end, if it's their call, if they feel that they don't want to continue the pregnancy, it is their call.
Because Chinmay, that bucket has the largest amount of dilemmas, because we think that, okay, they should be able to deal with it, but they don't want to deal with it. So that's really a tough bracket, because it is something that it's a gray zone. But the middle bucket, where definitely there are some process and procedure involved, and the last of all, where this baby cannot have any good quality of life, or there is some like anencephaly, for example. That's also a malformation. Then we know what to do. That's the easiest thing to handle, because in itself, whatever we have picked up is something which is not to be bought into this.
We have had anencephaly babies also that people are refusing to terminate because of religious issues.
But
absolutely. In that note, I'd like to share a case which recently, when it's still ongoing pregnancy, we saw the fetus. The baby had a now microstomia, abnormal hands, and club feet, and we called the father, and he looked absolutely similar. And then he said, I have Freeman-Sheldon syndrome, and I'm fine. I'm eating everything. I'm fine. I've had surgeries, and he's a brilliant, he knows everything about it. And we said, oh my God, and he said, I will bring up my child. But I was just thinking that, and they're continuing their pregnancy. They're going to go and
get two families with achondroplasia like that, and they are very happy, and they are continuing their families like that.
I was just thinking that if tomorrow this child comes and tells me, you have put me through so much, is it? I mean, the father has obviously made the decision. The mother is quiet about it. He said, I'm perfectly fine. I'm doing everything. He is very brilliant. He's intelligent, and he has absolutely no other problems except for these physical deformities. And it's proven in the baby. The baby also has that. We've done the genetic, but they are continuing. So it's up to the couple.
But Chinmay, that's why the word of shared decision making is really, really very important, because there are some of the OB-GYNs who just pass it off. They take their own judgmental decisions and this or that, and they sometimes make the patient feel guilty that, oh, for cleft lip also, as Bijoy said, they don't want to continue, but we are telling them, oh, for such a thing, we make them feel guilty that they're wrongly terminating, etc., etc. So shared decision making is a soft and
I'm just sharing this particular case for some of my fetal medicine colleagues who will realize this patient had lost 2 babies in the past, has been worked up for some genetic conditions, and nothing was found common in the parents. But this time there was this kind of pleural effusion in early pregnancy. This is 16 weeks. And then when we saw that further, we actually did the genetic testing because the parents were matched for something or the other, and there was nothing contributory. Everything was normal. And then you see here at 20 weeks, this was the level of pleural effusion. Should we intervene? Should we not intervene here? Genetically proven normal, recurrent losses due to high drops.
all genetic tests were normal, including an
All,
exome.
including an exome. Trio analysis normal. We were like hitting our head against the wall.
So we assess whether the heart is under stress. So we will do a functional cardiac evaluation and a cardiovascular profile. And if the heart is stressed, we need to aspirate. And if the heart is not stressed, we just wait and watch and call her back every week and see what's going on. And if
So we did aspirate once,
stress,
and we aspirated and sent it for thing. It looked like chylothorax. So she was just followed up, and there was no sign of cardiac compression due to the effusion, taken up conservatively every 2 weeks, and it just went on. That was the 16-week picture. Then you have the 20-week picture. Then you have the 28-week picture. And then you have the other picture. And this was, I think, yesterday. No, this is 28 weeks. You see, it's still going on fine. And I saw this patient yesterday, see, 2011. And just, it's completely gone. It's completely gone. And the lungs are absolutely fine. And now she is 35 weeks, 6 days. And she's gone on. I mean, she's very thankful and gone. I don't know, Abhi, she'll wait for another 2 weeks and then deliver. So something which can look as dramatic as that in mid-trimester can completely resolve. And therefore, my humble request to the obstetricians is please don't jump and, terminate these pregnancies without thinking and giving them a chance to work up, because she's lost the previous 2 babies for some reasons. There are some kind of genetic workup done. Everything is wishy-washy in the sort of history, if you look at it like that. But when you start clearing the cobwebs and see how things have cleared, there's really no problem there. And there was some kind of effusion here, which was chylous, and it's now settled down.
Chinmay, there's one big bang question here. Intracranial echogenic focus alone in the scan and intracardiac echogenic focus alone in the scan. These are commonly overcalled, misinterpreted, etc. So they want to know the opinion of what to tell, how to counsel.
Intracardiac echogenic focus, Khurana sir.
So there is no controversy here. There is only stupidity in terms of what we want to learn and what is new, and complete stupidity on where we use as reference points, such as Instagram and Facebook and Google. And the fault lies with society, and the fault lies with counseling. There are 15 things to be done when we handle a patient with a problem. 14 of them are counseling, and 1 of them is referral to a fetal medicine specialist. If we counsel our patients adequately, we know that nothing else needs to be done. If we spend time with our patient, we know that nothing needs to be done. You and me don't have the time either as fetal medicine specialists or as obstetricians. We need genetic counselors, and Bijoy should open a college for medical counselors, genetic counselors, and be the principal. And we need 600 of them every year for the next 5 years.
Yeah, so in the meanwhile, the interim solution, what we are trying to find is networking with all of you and providing online scheduled counseling where even other OBGYNs can observe what is being done and what's being told, so that they can get the know-how of many, many such instances to take back many more messages. Because as Chinmay says, and we all agree, that the discussions can go on forever and ever. Looks like these are her last few slides, after which I want Dr. Gupte, who's been patiently waiting, to just let the audience know and our experts know. He's written a book in Marathi on genomics for lay people, which is a bestseller, because there is also a need to create awareness amidst the community towards what we are actually discussing on this forum. And he also has a huge genetic lab with exome sequencing, this, that, and all, many of the things which I can't relate to. So that is another fine establishment. So we will let him have his one final comment. And Chinmay, is for you to wrap up this panel before we move to Dr. Gupte. Yeah.
So one of the reasons why people hesitate in continuing fetal anomalies is the care that they have to do. And Gupta sir also alluded to that what it means, the physically, the cost, the efforts that they put. So our vision would be to help these couples by the counseling that sir just told, and multidisciplinary care coordination, to help health insurance for sick fetuses. That is one aspect of care which we have to think of, because it's very difficult for congenital anomalies for patients to get medical insurance cover, and the government has to think of the unmet need of fetal care allocation. And we are very, very thankful to Professor Khurana to have started the Society of Fetal Medicine, and increasing this interdisciplinary awareness and involvement in fetal. Today, the way people are motivated to take up fetal medicine is something which is dramatic, and it's really helping in improve that. So I'll just wrap up with these two important cases with like my humble regards to both these set of parents. This is the scan of a baby who was a fetus of parents with both of them having microphthalmia, severe microphthalmia. And they had come, both of them were quite impaired. They were teachers in a school, and these pictures are almost 7-8 years back, and they've sent me recent pictures with the girls who've had their half sari functions also. And they continued that first pregnancy despite knowing that it was bilateral severe microphthalmia. And they said, that's okay, we'll take care of it. Just like we had a life, she will have a life. And I took care of their second pregnancy also. And as you can see, the second one is pretty okay. She had good orbits. But despite being, disabled themselves, they opted to take care of the girls, and they've given them beautiful lives. Both of them are doing extremely well. And this increases our respect for, parents who take care. Similarly, this is another couple who continued the pregnancy, knowing that there was a diaphragmatic hernia at 18 weeks. Went all the long way. We did every workup that was possible, but the child was born and did not do well after birth. In fact, the ventilator was pulled out because the lungs were good in volume but did not recruit. And this is what she wrote. I don't regret my decision because my child did not end up becoming medical waste product of termination, but saw the light of this life. And I'm a mother today, and a fetus came into this world with a name. And I have a new identity. I'm the proud mother of Pradyumna. So how patients look at their pregnancies is very different. And we can sit in judgment in many roles, but we should not forget that there is definitely an emotional aspect to every pregnancy. And sometimes the decisions that are taken may not be, cutting edge in terms of the scientific equivalence of that decision. But pregnancy is not just a scientific condition. In fact, medicine altogether is not just a scientific condition. So this dilemma of what the wise mind will think, what the rational mind will think, or what the emotional mind will think will continue. And we must have discussions on ethical dilemmas, because we cannot forget that we are not robots and we are not machines, and we are driven by the emotions of our patients. So the rational way is to identify the problem, evaluate options, and then apply the most corrective methods. And we will make mistakes. We will make mistakes because whatever we have done cannot be correct on every count. But making mistakes is not a problem. Not learning for our mistakes is a problem. We should avoid making future ones. And every time, take a history properly, look to the present properly, use evidence-based thing, and always ask the patient what they want. This is something which I think we must just revise once, that from inability to let well alone. So if that microphthalmic parents were happy to have that microphthalmic baby, just leave them alone. Let them have the baby. Let them take care of it. If that mother wants to just take care of a baby, there's a hypoplastic left heart. The mother says, it's okay, I'll hold her for a few hours before she goes. Doesn't matter. From too much zeal for the new and contempt for what is old. From putting knowledge before wisdom, science before art, and cleverness before common sense. From treating patients as cases, and from making the cure of the disease more grievous than the endurance of the same. Good Lord, deliver us. We all read this in medical college, and I'm thankful to Hema ma'am who's given us an opportunity to revise this, because we will have to remember the first principles of medicine. We follow the guidelines, but we don't give up on the wisdom and common sense that we have accrued over the years, and do whatever does least harm to the patients. So there is no ethical dilemma in this aspect, that however high risk the patient is, we will first do no harm. Thank you so much for a very, very patient hearing. And if my esteemed panelists want to give some message, we are more than welcome.
Yeah. One liner from each one of our brilliant panelists before we go to Dr. Gupta. Bijoy.
If, I would say that Chinmay has actually wrapped it up very well. There is nothing more to add. I would always say that we shouldn't, what do you say, stigmatize anyone for taking a decision. When we glorify someone taking for a good decision, we automatically stigmatize the parent who does not want a cleft lip palate child, or does not want a baby with a hypoplastic left heart, or does not want a child with microphthalmia. Let us give women the right to decide what they want. Let us just provide them with information, and that is the sole purpose of scanning or any kind of screening. Give them information, let them decide, and respect that. Let us not stand in judgment. I think
Well,
that's what
Vijay, when you say give them information, the whole forum of discussion is to give them the right information. That's why we
Yes.
need to brainstorm again and again and again. The way Dr. Khurana said, it's stupid. Even today, we have so many patients coming with that single cardiac, that echogenic cardiac. It just still haunts me how people are still anxious about that because they've been told to pay attention to that and they come with sorry faces. So that is why the correctness of information, that's why these forums are so very important for us to speak out loud and clear about the few facts that we are clear about. And of course, there may be lot many which will still get even ourselves at any point in time with the dilemma. So that is my 2 cents to my wrap up, which I finished. Now we'll go to Dr. Khurana next.
I want to add nothing from what has already been said, but except to tell everyone that I hope that webinars like this are the beginning and not the end of a discussion. This is our starting point on how we handle knowledge, how we handle co-human beings, and how we handle human responses. We have the wisdom, we have the knowledge, we just have to learn how to handle it. And my special thanks to Dr. Hema and to Dr. Sanjay Gupta for taking this lead in guiding us on what is really best for our patients. We are all pawns in the larger game. We should acknowledge that we are not God and we should not play God.
Thank you so much. Well said, Dr. Khurana. Bela?
So completely agree with all the dignitaries that we are here to just provide information about the unborn child to the parents and the family and let them take decision. As Dr. Chinmay mentioned about that case of microphthalmia, I had a case where Treacher-Collins syndrome. Both the father and the grandfather both were suffering from the same. And I did the anomaly scan and it was showing so many facial dysmorphism. One ear was abnormal, the other one was almost absent. But the parents, they said, we want to continue. There are 2 generations. One was the father had little deafness, the grandfather didn't have deafness, and they said, we are completely fine with the features, and even if there is deafness, we want to continue. They continued with the pregnancy. So it's very, very important to respect the feelings and the wishes of the patient and the family. And we are not here to take any decision. We are just here to help them make informed decisions.
Thank you, Bela. Sita?
Thank you. I think as everyone said, everything's already been said, but one is that don't be judgmental. And even if they take whatever decision, there's nothing right or wrong here. We have to put yourself in their patient's perspectives. So whatever decision is there, just guide them and support them through their pregnancy, whichever way it goes, and be there for them whenever they need you.
Absolutely. Yeah. So thanks. That is going to be Dr. Bhaskar Paul's slogan for the whole of the next year for Foxy. Thank you, Sita, for being here with us. Chinmay will rightfully wrap up with her comment before I go to Dr. Gupta.
Oh, no, absolutely, ma'am. You've made all of us say what we wanted to say from our hearts, because practicing fetal medicine or practicing high-risk pregnancy care is not easy. And there are always difficult decisions. So the first part is to acknowledge this difficulty. That makes it very important. Like I always said, what is right is hardly ever easy, and what is easy is hardly ever right. So to do the right thing at the right time and to take the decision, we have to respect. I completely agree with what Bijoy said. No judgments. Whatever is correct for one patient works for. Keep the patient at the center of everything. And thank you so much for this opportunity, because this is really something which is satisfying to our hearts.
Brilliant. Thank you. Thank you, Chinmay. Dr. Gupta?
Yes. Thank you, Dr. Hema. Trust you to collect the absolutely right people for the right cause. were talking about ethics, and everyone on this panel was so wonderfully expert in the ethical aspects of it, starting from Dr. Khurana, Dr. Vijay, Chinmay, Bela, and of course Sita. I think we have experts, ethical experts in our own country, and I think this would inspire us to have our own bioethical, the course we should have for our own country, because our aspects are different and we may require a little different. So this inspires me to think about it, that let's collect people like this who are very correct in their thinking and very correct in their judgment and are very ethical, and start something new and bringing those ethics and conveying those ethics to our colleagues at large and see how they are followed. So wonderful. I thank all of you. I learned a lot from this, and I think everybody was brilliant today.
So we are
Thank you, sir. Thank you
we
so
are going
much.
to announce the college by Bijoy. that is in the making now. So Bijoy, you have to take this point ahead, because we need some leaders to move the needle ahead, because we all have recognized that this is, everything is difficult before it becomes easy. So this is a new era of thinking, which is at the cusp of, growing bigger, because there will be many questions within our own minds. There will be questions from the parents. There will be questions from the community. There will be questions from the activists, with the policymakers, with the legalities, with everyone who is a stakeholder in this entire, because everybody wants a perfect baby. Everybody wants a guarantee that all is well. And that is quite a paradoxical wishful thinking, if I may say. So I will again leave it with Dr. Purni, and on my own behalf, very, very, very sincere thanks to all the speakers and the brilliant panelists, and continue to inspire us with a lot of good work that you would continue to do for a long, long time to come. And PharmEd, which has not insisted ever that any of the knowledge cafes should have any discussion pointed to their products. They just leave the floor open to our discretion and our decision on what should be deliberated. So thanks very much for the leadership of the PharmEd, which is recurrently, consistently, persistently holding us on to several of the Knowledge Cafe series. The Netflix and other OTT channels have C1, episode 1, 2, 3. They have labeled this also similarly. So many more to go as we go along. So Purni, kindly, official thanks from Dr. Diwakar and myself, voiced through Dr. Purni. Purni, please.
Thank you so much, ma'am. Even though during the entire discussion we kept saying, in the interest of time, I'm sure if this would have gone on and on, the whole audience would have just loved to listen to more and more of this. But however, I guess we have all good things come to an end. But like Sir said, this should be the beginning of more and more dilemmas in our mind and discussions in our mind. A very big thank you to, of course, Dr. Hema and Dr. Diwakar, Dr. Sanjay Gupte, for giving us such an elaborate and well-spoken talk, and Dr. Chinmay for that wonderful moderation of the panel, and all our esteemed panelists. And of course, thank you to PharmEd and all our delegates who have joined and sat through. A very good evening to all of you. Good night.
Thank you very much. Namaste.
Thank you so much.
Right. Good night.
Bye-bye. Bye, everyone.
All dignitaries, thank you.
Bye-bye.
Wonderful learning.